here's just a taste of what you can expect coming up.
Because these patients look well, there's a sense that the side effects of the drug are worse than the disease itself, and that leads to a degree of therapeutic nihilism and a failure to appreciate the importance of trying to prevent progression of what is ultimately a fatal disease.
You very eloquently had Dr. Maher summarize the entire study in his British accent. It's hard to top that. So I think overall, I'll just say that the win here isn't just that drug A beats drug B. The win is that we have multiple options that enable us to now fit therapy to the patient's biology, to the patient's preferences, to their life realities, and help adjust them as the disease or the goals or the tolerance changes for patients. So that's precision medicine.
I think pulmonologists need to be comfortable with managing chronic disease, that managing IPF is different to managing asthma, for instance, different to managing infectious diseases like tuberculosis, and it's very different to the sort of day-to-day practice on the critical care unit that is sort of the bread and butter of many of our pulmonology colleagues.
Every breath that's made easier, it's meaningful for patients. And that's the work you have to do. That's the work we also have to do. And together, primary care, pulmonary medicine, radiologists, rehab, pharmacy, palliative care, all of us together with the patients, we are shifting the silence around this disease into a coordinated, compassionate chorus that makes sense for our patients and hopefully improve outcomes for them as well.
Hello, and welcome to this episode of the AMJ podcast entitled Shifting the Silence, the Evolving Landscape in Pulmonary Fibrosis, a Decade Without New Options. I'm your host, Sue Saville, and I'm delighted to be joined today by Professor Toby Maher, who is Professor of Medicine and Director of Interstitial Lung Disease at the Keck School of Medicine, University of Southern California. He previously led the ILD unit at the Royal Brompton Hospital in London and currently holds a professorship at Imperial College in London. And he's led more than 50 ILD trials and authored more than 270 publications. Also, thrilled to have with us Dr. Ayodeji Adegunsoye, who is Assistant Professor of Medicine at the University of Chicago and the Scientific Director at the UCMC Interstitial Lung Disease Program. He has a doctoral degree in genetics, genomics, and systems biology, and a strong interest in prognostic modelling, the genetics of pulmonary fibrosis, and addressing healthcare disparities. His research focuses on clinical prediction models. Well, welcome to you both. Great to have you both with us.
Thank you, Sue.
Thank you.
So let's start this episode by reflecting on the landscape of pulmonary fibrosis treatment over the last decade. I'm wondering, Professor Maher, perhaps first, how you'd characterise the challenges and unmet needs that have persisted in this field until quite recently.
Yeah, certainly. So I think the reason we've chosen a decade is because before 10 years ago, we didn't have any treatments at all for idiopathic pulmonary fibrosis. So anything we say is couched in the fact that for the last 10 years, we have at least had options, even if they're imperfect. The two drugs that we do have, pirfenidone and nintedanib, have almost certainly improved survival for patients. But unfortunately, they are often difficult for patients to take. Both drugs have significant side effects, particularly affecting the gastrointestinal tract. And we know from studies conducted across the US that as many as half of patients discontinue drug within 12 months of starting because of those side effects. And added to that, although our patients are undoubtedly living longer, they're still dying ultimately of their idiopathic pulmonary fibrosis. So we need both better treatments and better tolerated treatments for our patients to take.
And Dr. Adegunsoye, anything you'd like to add to that?
No, I think Dr. Maher covered it very eloquently. In addition, I'll probably just point out that we've had efficacy ceilings as well. Both of the antifibrotics that were mentioned actually reduce the rate of FVC decline, but neither of them cures fibrosis. I mean, patients still progress. The slope is just less steep than it was before. And that begins to matter clinically for our patients because, again, we know that slower decline buys time, but it still leaves patients and clinicians asking for more. And so that really has been a challenge we've encountered with these medications in the last few years.
And Toby, if I may move to first names, what about any additional challenges or significant barriers have you come across to the optimal care for patients with pulmonary fibrosis, perhaps in community or primary care settings, and any practical steps that you could advise community providers might be able to take to improve the quality of life for these patients?
Yeah, so I think there's a couple of problems we encounter frequently. One is a failure to appreciate how severe a disease idiopathic pulmonary fibrosis really is. When patients first present, often their only symptom is mild exertional breathlessness, and they look very well. So it's very easy to underestimate the danger that this condition poses to that individual. So I think first off, the disease gets treated as being milder than it really is. I think the second challenge really sort of comes back to the side effects, that because these patients look well, there's a sense that the side effects of the drug are worse than the disease itself, and that leads to a degree of therapeutic nihilism, and a failure to appreciate the importance of trying to prevent progression of what is ultimately a fatal disease. So I think that the key points to get across are this genuinely is a deadly disease, however well the patients look. And secondly, if we are really to make a difference for our patients, we need to be treating them early on when we can genuinely preserve normal lung tissue.
And Deji, if I may, your focus on health disparities, how does that play into the challenges and the barriers that you see?
Yeah, I think the well, I practice in the Midwest of the U.S. I'll state that to start with, and we have a very diverse population over here, and health disparities plays a big role. But I'll say over and above that, in our community here, we actually do face significant barriers to optimal care from the perspective of the primary care physicians or the first line pulmonologists. In my experience, three barriers show up again and again. The first one is time to diagnosis. All these symptoms like dry cough, exertional breathlessness, what we call dyspnea and exertion, these can often look like asthma or COPD. And patients just say, oh, I'm just conditioned. That's what it is. But I'll tell you that subtle features like crackles, they can be missed by our community providers. And the longer we explain symptoms away, the more lung function that we lose before the right CT is ordered. And so that time to diagnosis is a really big challenge which we encounter in our patient population. I do believe that if we are able to encourage ordering spirometry with lung volumes earlier and DLCO, and not being shy about HRCT patterns, if the picture doesn't add up in particular, then for those patients, we're able to speed up the time to diagnosis. The other thing I commonly encounter is a watch and wait reflex. I would say to our primary care providers, I get it. When a patient looks okay and the test results are borderline, it feels kind of nice or kind to the patient to watch. But the issue is fibrosis doesn't really bargain. When we delay referral of our patients, we delay pulmonary rehab, we delay oxygen therapy, we delay management of comorbidities. And now that we have antifibrotic therapy in both IPF and PPF, we also delay time to therapy. And that way, you delay the diagnosis, but also delay management and outcomes in these patients. So I often encourage a mindset shift. So I tell patients and providers, early action to preserve function is really critical. And that waiting for decline to prove itself, like we've done in the past, it doesn't really work for our patient population. And then the third thing I'll point out is the scope and familiarity. A lot of primary care providers or pulmonologists like to say ILD is a black box and they want to have nothing to do with it. But that doesn't help anybody. Community physicians in particular see oftentimes only a handful of ILD patients a year, and being able to coach them for side effect profile for these antifibrotics, what to expect, how to navigate prior authorization, referral timing earlier, all of these can feel very daunting to squeeze into a 15-minute encounter. And this is where I think checklists and simple pathways, algorithmic care, really begins to help. What trigger points for HRCTs do we have? Is there a specific referral threshold for ILD clinics where they don't have access to that? And is there a standing order you can click on for pulmonary rehab once you see restriction or diffusion limitation on the PFTs, even before a label crystallizes for the patients? So I think there are practical steps that can be taken to mitigate those challenges that we encounter in the community setting.
So, Toby, does this point to a rather outdated approach that needs to now move on in the light of current understandings?
And yes, absolutely. And I think certainly over the last decade, what we have seen is a better understanding and appreciation of how to treat chronic disease. I think for us in the pulmonary space, it was a relatively new innovation with the advent of treatments for IPF. I think as pulmonologists, we're often used to treating acute conditions like pneumonia or infectious diseases like tuberculosis. We've been less good at managing chronic progressive diseases typically associated with aging. And I think we've had the opportunity to learn from other fields. And what we're thinking about here with IPF is very similar to what the neurologists think about with dementia, or the endocrinologist with diabetes, for instance, or the cardiologist with cardiovascular disease. So I think we have been able to learn some good practice from them. And I think the sort of hopeful development of new treatment options really opens up the opportunities that we can provide to our patients. And I think will ultimately provide a sort of further evolution in how we think about the management of IPF.
So you mentioned new treatment options. Nerandomilast is on the scene, emerging as a treatment option. Deji, how would you say this is significant in the treatment of pulmonary fibrosis?
I think it's really significant for a lot of reasons. I'll probably highlight just a couple of them. It's new kid on the block, so hopefully we'll be hearing a lot more about this in the months to come. The first thing I'll point out is mechanistically, it's different than what we've had in the past. It's a preferential PDE4B inhibitor, which is different from our traditional TKIs, that's tyrosine kinase inhibitors. It sits right at the crossroad of inflammation and fibrogenesis. And so, by virtue of that, it shifts the biology of the disease itself. And so, when patients are able to get nerandomilast, it's a new lever, it's a new treatment, it's a new option in the disease landscape where we have just currently two really therapies for the disease, IPF or even PPF now. And so I think the general reason why we're excited about this was predicated on the Fibroneer phase 3 program that just recently met its endpoint and was published in the New England Journal, where patients who got this medication were able to preserve lung volume about 120 cc's or thereabouts over a 52-week period, depending on the dose as well in IPF and in PPF. And so I think we're excited about it. While not being a cure, it's a clinically meaningful preservation of lung function, and it's a long-awaited addition to our toolkit in pulmonary fibrosis. So what really excites me about is what could this new therapy unlock for our patients? I think first it really begins to give our patients who couldn't tolerate existing antifibrotics a new option. We can finally talk about a new target that's different from what we've had in the past, with a different side effect fingerprints, really. Secondly, I think it also brings to bear the opportunity to leverage combination therapy for our patient population, which we didn't really have in the past as well. When I think of other chronic pulmonary disease conditions, you often are able to give two or more drugs for the same condition to optimize efficacy. We didn't have that. So being able to do this now in the pulmonary fibrosis landscape is a really, really cool thing for our patients and for care providers as well. And then thirdly, I'll just add that I think it adds what we call a new class signal to our patient population, in that we now are able to access a new class of medications different from what we had before. And that enables us to stay balanced in terms of balancing or spreading out the side effect profile while optimizing efficacy for our patients with pulmonary fibrosis.
And Toby, perhaps in your specialism, it's not that often that a new class comes along. What do you feel is the significance of this now?
Yeah, well, as we've alluded to at the start of this podcast, it's been a decade since we've had any new treatments at all. So it is exciting both to have a new treatment, but a treatment with a new mechanism of action. And I think there's two key opportunities that it provides. First of all, it gives us a new potential therapy. So we, instead of having a choice of two, have a choice of three. But before now, it's been impossible to combine treatments. So although there's been some evidence that nintedanib and pirfenidone given together are perhaps more effective than either drug on their own, because of the GI tolerability issues, it's been impossible to give patients the two drugs at the same time. I think with nerandomilast, as we saw in the Fibroneer clinical trials, it is possible to give it on top of the existing treatments. And so we now have the option that we can give combination therapy to patients who are failing to stabilize on any single treatment. And that really is something new for us to be able to do. And I'm optimistic that will hopefully add to the benefits that we've seen with antifibrotic therapy before now.
Thank you. So let's look a bit more closely then to understand the latest clinical trial data, looking more closely at the Fibroneer clinical trial program. What then are the key takeaways from the recently published data on nerandomilast in idiopathic pulmonary fibrosis and progressive pulmonary fibrosis? Professor Toby Maher, could you give us a little bit more detail on what those key takeaways are?
Yeah, so I think, as you've said, there were the two trials, patients with idiopathic pulmonary fibrosis, Fibroneer IPF, patients with other forms of pulmonary fibrosis that we know progress that aren't idiopathic pulmonary fibrosis, so Fibroneer ILD. Broadly speaking, the overall result, the effect of treatment on slowing FVC decline was very similar. So in both studies, the drug was clearly effective at slowing worsening in forced vital capacity. And the reason that is important is because at the population level, we believe that FVC is a surrogate for survival, which is to say, the faster FVC gets worse, the more likely patients are to die in the short, medium, and long term. And so by slowing FVC progression, we're ultimately saying that we expect patients to live longer with treatment. So I think that was the first key finding. There was an important observation in the IPF study where patients were allowed to be on either background nintedanib or pirfenidone, that there was a drug-drug interaction with pirfenidone that reduced the effectiveness of nerandomilast. So the way the trial was designed, nerandomilast was trialed at two doses, 18 milligrams and 9 milligrams. In patients on no background treatment or nintedanib, both doses, the 9 and the 18, appeared to be equally efficacious. But with patients on pirfenidone, the 9 milligram dose seemed to lose its effectiveness, and that was because the pirfenidone interfered with the metabolism of nerandomilast and reduced the plasma exposure. So we know patients with pirfenidone will need a higher dose of nerandomilast to get the benefit. In the ILD study, where we didn't have this interfering effect of pirfenidone, we saw an even bigger magnitude of benefit on the FVC than we did in the IPF study. We also saw a trend towards improvements in the secondary endpoints, which included a composite of survival, time to respiratory hospitalization, and time to acute exacerbation, which is sort of what we would expect by slowing the FVC decline, but it's always very reassuring to see that signal emerging because it provides additional evidence that the drug is really going to improve outcomes for patients. And then I think the thing that we were all looking to was the sort of safety and tolerability data. And I think one of the key takeaways for me was that in the nerandomilast treatment arms, there were no more discontinuations than there were in the placebo arm. And that's very different to the pirfenidone and nintedanib trials, where more patients on treatment discontinued drug primarily because of side effect, whereas we didn't see that in the nerandomilast trial, which tells me that this drug is almost certainly much better tolerated by patients than either pirfenidone or nintedanib. And to sort of take that a step further, when you sort of dig into the side effect data, there is a very small gastrointestinal signal. Nerandomilast on its own causes a slight increase in the frequency of diarrhea, but it's mild to moderate diarrhea. It's not diarrhea that leads to treatment discontinuation. The only scenario in which we saw more significant diarrhea was when nerandomilast was given together with nintedanib. So although it wasn't terrible, the nerandomilast nintedanib combination does have a degree of diarrhea associated with it. So it's not 100% perfect, but it really does look to be a step change in terms of tolerability for patients.
And Dr. Deji Adegunsoye, thinking about the safety and the tolerability and the factors there that Toby's described, as a clinician, what are you taking into consideration, perhaps for special populations?
Yeah, so you very eloquently had Dr. Maher summarize the entire study in his British accent. It's hard to top that. But I will tell you, from the point of view of a community provider, at least here in Chicago, Midwestern US, safety is a big issue, particularly in our vulnerable populations. And so I'll point out that in both trials, diarrhea was the most common adverse event. That's not surprising to us because we know this with underfibrotic landscape currently. But the overall safety profile looked very similar to that of placebo in the PPF trial, the Fibrinogen PPF trial in particular. And this included the serious AEs and discontinuations, which is, again, very, very reassuring. What does that mean for us? It means that we can actually now plan for side effect prevention in our patient population, hydrating patients appropriately, tweaking their diets, giving anti-diarrheal therapies as necessary, and following these patients early on, like we do already for existing antifibrotic therapies. The other thing that I thought was really notable about this is the hepatic effect on the liver function test, which we have historically done for patients who are on antifibrotics. In this case, that was really, really minimal. In fact, we don't, unlike pirfenidone or nintedanib, which you've had in the past, this suggests that we probably wouldn't need to closely follow the LFTs like we did in the past, meaning less frequent hospital visits for patients, less cost of care in terms of access to care. That is not as necessary as it was before. And a lot of things are now much better in terms of the side effect profile from this medication. And then I'll point out as well the class effects I alluded to earlier on. When we think about the traditional oral PDE4 inhibitors like roflumilast, which we use often for COPD, it's known for causing GI upset and weight loss, and sometimes even the neuropsychiatric symptoms. With nerandomilast, you have a targeted effect. It's a preferential PDE4 inhibitor that's designed with the aim of, while it improves tolerability, it preserves that anti-inflammatory and anti-fibrotic activity. And so that way you have a much better side effect profile that obviates the need to monitor for neuropsychiatric effects, which we didn't really see in the clinical trials. So I think overall, these trial data helps us keep our expectations more realistic and almost side effect free. It's not exactly side effect free, but it's a very, very tolerable profile that helps us to navigate patient situations with good counseling in their hospital course or clinical course.
And Toby, beyond the insights into lung function preservation, what else have you learned from these trials that might be helpful for the patient's quality of life, disease management, according to the data that were presented at ATS this year?
Yeah, so the quality of life piece is a very challenging one in clinical trials. We know that idiopathic pulmonary fibrosis ultimately does affect quality of life, but it tends to do so more towards end-stage disease once patients can't undertake activities of daily living. So for the average patient in a clinical trial, their primary symptom is exertional breathlessness. So when they're walking, they get short of breath. And most patients can avoid that through lifestyle modification. So instead of walking to the shops, you drive, and so you overcome the issue of your exertional breathlessness. And so the problem we have in our clinical trials is trying to find a way to tease out the impact of disease on quality of life and then to show change with treatment. And we haven't successfully managed that yet. The questionnaires that we use, which essentially function by asking patients about breathlessness in different circumstances and how that limits them, those questions are relatively blunt at getting at the symptoms in earlier disease, and they tend to work best in the patients who've got really severe breathlessness and are often oxygen requiring, who don't tend to be the patients that go into our clinical trials. And so that's a very long-winded way of saying that in the Fibrinogen trials, we didn't see a significant impact on quality of life. And that's not because I think treatment ultimately doesn't benefit long-term quality of life for patients. It's because I think we're just not very good at being able to measure impact on quality of life. My personal supposition is that if we can slow disease deterioration, if we can prevent the development of respiratory failure, if we can delay the need for oxygen, which is a signal that we saw coming out of the Fibrinogen IPF study, then ultimately we can expect over the longer term that we will have an impact on patient quality of life. But when we just look at the trial results, we can't see that. And I think that's an issue of measurement rather than a lack of effect.
Thank you. Well, let's think a little bit more closely, perhaps about from hesitancy to action, reaching the community clinician. Deji, we talked a little bit earlier about that watch and wait mindset that can exist in community settings. What is it that contributes to that inertia, and how could that perhaps be overcome?
I would like to add a few things about the quality of life question, in addition to what Toby eloquently stated. And then I can hop onto the hesitancy to action as well. I do think that a few things also stick out from the clinical trial data that probably are worth pointing out. So at least in my practice, two things I find resonate with patients a lot. One is, will I need oxygen? And two, will I feel better longer, right? We hear this a lot. And so the data, at least some of the analysis from the nerandomilast trial suggests that there may be fewer patients who are started on supplemental oxygen over the course of a year with nerandomilast when compared to placebo. Amongst those not on oxygen at baseline is what I'm saying. And that's kind of intuitive because I think it suggests that the more you preserve FVC, the more you can potentially delay hypoxemia. And that becomes practically meaningful for daily life, for travel, for our patients, for work, and a lot of other daily activities. Again, it's supportive evidence. It's not causative. And I think we just want to see much more analysis that elucidates the underlying reason for that. The second thing I think is what pointing out is a complementarity in the treatment patterns, right? You see that FVC preservation in this trial seems to correlate to better patient-reported outcomes over time, and that's what we experience in the real world. But in the clinical trial, there was no evidence suggesting that specifically. And we know that questionnaires also don't dramatically move in terms of outcomes at 12 months. Typically expect a longer period of time for you to see a really more profound effect. So I think overall, as Toby mentioned, the message to patients should be honest, it should be hopeful. We can't eradicate the disease today. We can't erase it today. But we can often protect lung function better. And that protection is really what lets us do more of what matters to us while we are on the currently available therapy. And I think that means a lot. I might hop on now to your earlier question about what do we do from a hesitancy standpoint? What drives the watch and wait approach, and how can the data help us get beyond this? So in the community practices, I think that a watch and wait can feel very compassionate. As physicians, we are taught to first do no harm. No one wants to burden the patient with side effects or a scary label of pulmonary fibrosis before it becomes necessary. But the sad truth about the matter is pulmonary fibrosis doesn't wait. Right, the natural history may be variable, yes. Declining lung function may fluctuate, yes, particularly FVC, which we know is affected by a host of different conditions, but it also tracks with outcomes, right? And we know that a subset of patients that we care for on a daily basis, they progress rapidly. And so I think that becomes necessary in light of recent guidelines from 2022 that suggest that we should look at the term progressive pulmonary fibrosis, which is a behavior, not a specific label or a diagnosis. And when that behavior shows up, it's time to act. We need to step in and abandon the watch and wait approach. And so from my experience, I would say three things actually feed inertia in terms of treatment. One is the historical fear from our patient providers, right? We have data actually that even supports that. The Panther IPF treatment from 2011, it taught us that using anti-inflammatory cocktails, what we call immunomodulatory therapies, it could begin to harm patients with pulmonary fibrosis. And so I think the field became appropriately cautious after that, which again sounds appropriate. The second is misperceptions that we often encounter, right? A lot of people underestimate how often mild disease can speed up or accelerate, even from what we term near normal baselines. And then thirdly, there is a confusion about signals, right? Symptoms wax and wane, patient signs fluctuate, the FVC itself may drift slowly until it doesn't drift and just precipitously drops. And so we often assume that more time will buy us clarity in caring for these patients. That's not true. In reality, earlier action often preserves more function than waiting for proof in hindsight. So I think that the data that was recently published in the Fibronia IPF trials for nerandomilast begins to change the game. It changed the narrative for us, right? It tells us that, look, if you implement a first-in-class PDE4B inhibitor in this space, you can actually have consistent 1-year preservation of FVC, not just in IPF, but also in PPF. Again, is it a cure? No, we said that already, right? But it adds a new mechanism beyond our conventional TKIs, and it actually has demonstrated benefit that can help optimize patient outcomes.
And given that, then, Toby, what strategies have you found effective for discussing treatment options with patients when you're addressing concerns perhaps about side effects or uncertainties about treatment benefits?
I think it's important to make sure that people with the disease, first of all, understand how serious the condition is. Because when we consider sort of side effects and the pros and cons of taking a drug, one has to balance that against the potential risk of bad outcomes with the condition itself. And so, we think very differently about treating a self-limiting lower respiratory tract infection in a healthy individual versus how we think about treating a life-shortening and life-threatening disease like idiopathic pulmonary fibrosis. And I think what tends to happen, as I've perhaps already alluded to, is that physicians underestimate what a serious disease IPF is, and often will then provide false reassurance to a patient that they don't have a serious condition, that there isn't a great need to take treatment. And that results in a situation where a patient who feels well, who's only got a little bit of mild breathlessness on exertion, doesn't want to take a drug that might cause them diarrhea because that seems like something that is far too inconvenient. If, on the other hand, that patient understands that there is a very good chance that this condition will kill them through respiratory failure in 3 years, then that internal calculation they make as to the value of taking treatment is completely different. And it's very hard to argue that the drug is worse than the disease when the disease is fatal. So the first step for me is to help patients and their family understand the disease that they're dealing with. It's fair to say that Google makes life easier for us, because if you Google idiopathic pulmonary fibrosis, you're going to come away terrified. So often I actually have to even pull things back slightly from the position that Google has left patients in, thinking that the end is nigh. But
May I just say that other search engines are available?
That is true. So that's step one, I think, is educating people about the disease. Step two, certainly to date, has been educating patients about management of side effects, because often lifestyle change can have an important impact on the side effects. Change in diet can often minimize or reduce a lot of the problems we see with gastrointestinal upset. So again, when prescribing the drugs, I will explain the pros and cons of each treatment, but I will also explain the strategies that we can take to help patients tolerate treatment in the longer term. And then, certainly within my institution, I'm fortunate to have a team of nurses and a pharmacist who will also go in and provide education and reassurance to the patient. So we spend quite a lot of time working with them, explaining the rationale for treatment, what the treatment will involve, and how we can help mitigate side effects. And then obviously, as part of the conversation, we discuss the availability of the two treatments, the differences between those treatments, the differences in dosing regimen, the potential differences in side effects. And we help them make a choice as to which of the available treatments they feel are going to suit them best based on their sort of lifestyle and concern about specific side effects.
How then might the availability of different treatment mechanisms change treatment decision making for different patient populations?
Yeah, so I think that generally, when I encounter patients in clinics, I typically want to start by setting expectations, right? I tell them that there's no cure today. We can often protect lung function today and then buy quality time. But again, protection is not perfection. That is the goal: protection of your lung volumes and helping you sort of walk through the disease in a way that makes sense. And it's always going to be a shared decision making pattern. But when it comes to having different mechanisms altering the disease profile and interventions and decision making, which should always be taken in concert with the patient and their loved ones, I think we want to often tailor the treatment to the person, right? And having different mechanisms lets us do that really elegantly. It's not just a disease we're managing, but we're taking care of a whole individual, a whole person. And so I typically think about it in layers. I think about the disease biology and the behavior. In IPF or in PPF, we know that it's almost uniformly you're going to have progression, varying degrees of progression, but you have that. And any therapy really that preserves FVC becomes valuable for our patients. We know the TKIs target pro-fibrotic pathways. Now you have nerandomilast, so that's PDE4B mechanism. It's more of a balance between the inflammation fibrosis interface, and it opens the door to sequential use, right? Patients who've been on one therapy before can now switch to a different therapy, or those who have an inadequate response previously can actually have adequate response now. And so it opens the door to combination therapy in select cases, but also sequential therapy for those who had ineffective response previously. The second part of it is the comorbidity profile of our patients. With PDE4 inhibitors, we're able to anticipate GI effects and check for what we call the CYP3A interactions. These are interactions that happen through the hepatic pathway, where strong inhibitors like antifibrotic therapies can increase exposure to the drug. And so we're able to check for these interactions in advance and mitigate them. With TKIs, we're able to reinforce the fact that diarrhea and nausea can happen. We'll plan for it and watch for hepatic interactions. But we don't need that necessarily with nerandomilast because it's a very different mechanism of action. And so now I think in 2025, we're able to match the mechanism to the patient's specific risk profile and what they can realistically tolerate, right? Because not all patients are cut from the same cloth, right? Each patient is different. And then I think it also enables us to think more carefully about the stage of disease that the patient may lay in. For example, earlier disease with subtle symptoms really is where you want to actually intervene as much as possible, because preserving the slope of decline early on pays off down the line. We like to tell patients lung function loss can never be regained. And so why don't you intervene much early before the slope becomes precipitously down inclining, right? And so advanced disease also needs equal attention as well. I won't just say ignore that, because again, you want to pay attention to symptom control, pay attention to oxygen initiation where necessary, pulmonary rehab as may be needed. And there are other goals of care that you want to think about. But again, thinking about this for this patient in front of you to target therapy or care towards that patient in particular. And then lastly, I'll talk about the delivery of care, which I think is really important, particularly in our community settings, right? We've seen a lot of emphasis in recent times on the virtual MDD profile, the multidisciplinary discussions. And in tertiary centers or ivory towers of learning, most providers or subspecialists can meet in the same room on the same day at the same time and discuss any one patient. In community settings, they're not often so privileged that they can actually afford to do that. But we've seen a lot of people now leaning more on telehealth mechanisms, on virtual conferencing or e-consults. This is really important because the evidence is clear about this. Multidisciplinary review of patients improves not just diagnostic agreement on what is fibrosis, what the extent is, but it also helps to refine management of these patients. And so we're seeing a pivot more in the last few years towards tele-enabled models that are, I think, increasingly feasible given IT and the resources we have for our patients now. So I think overall, I'll just say that the win here isn't just that drug A beats drug B. The win is that we have multiple options that enable us to now fit therapy to the patient's biology, to the patient's preferences, to their life realities, and help adjust them as the disease or the goals or the tolerance changes for patients. So that's precision medicine pretty much.
And thinking then a little bit more about the fact that patients differ, not all patients are the same, let's consider a bit more about patient-centered care and what psychosocial support can be available. Toby, what do you think are the main challenges that patients with pulmonary fibrosis typically face in terms of the psychosocial side of things, and how might healthcare providers better address this for them?
There's a lot there to unpack. I think, the first step or the first major component is, of course, patients are faced with their own mortality. They've been diagnosed with a potentially fatal disease and all that entails. So I think that is a big burden for patients to deal with in the first place. If we have a disease that has an outcome that's very similar to many cancers, and yet if people are diagnosed with cancer, then there's a whole support process that swings into place. And also, they can easily communicate to friends and family the situation that they find themselves in. They don't have to explain to people that this is a bad disease. Whereas with IPF, there's very little awareness of the disease outside of medical circles. There isn't that automatic sort of sympathy and support that kicks in from friends and family. Patients find themselves in a situation where they have to explain their disease to other people before they really get any support from those individuals. So I think that's the first challenge is dealing with what is almost a hidden disease that is undoubtedly fatal. Clearly, as the disease progresses, patients have to sort of live with the limitations imposed by their breathlessness and their respiratory failure. And I think, again, another problem they run into is the blindness of other people to the challenges faced by an individual with IPF. Because often when you look at someone with IPF, even when they've got really advanced disease, when they're sitting still in front of you, they don't look any different to the three of us on this podcast. You wouldn't be able to pick out the IPF patient necessarily. And yet they know that the second they try and do anything, they're going to hit a brick wall of breathlessness. And so that in their mind they can do it, but as soon as they try to, they can't. And so that creates a lot of frustration. And then there's also the effect on family and loved ones. The disease often puts a huge burden on spouse or carers or children, because as the respiratory failure develops, patients with the disease become very dependent on other individuals to be able to do things, whether that's washing or dressing or having someone cook and provide for them, because although they would love to do it, they just physically can't. And so they often have to come to terms with that dependency, and their family have to often need support in helping patients deal with the disease. So again, in our practice, as I've said, we have a team of nurses, we have social workers, we have a dietitian, all of whom will work with these different aspects of the disease and the sort of the coping strategies that go with it with our patients. And actually, last week we just had our patient day where we get our patients up, and one of the parts of that is for the last hour, our social workers basically sort of sit down and allow the patients that have attended to have an open discussion with each other and share ideas on how to cope with the disease. And it's always very interesting to listen to what comes out of that, of how people have developed coping strategies, how they've learned to communicate to other people outside the family what it is they're dealing with. And I think we shouldn't underestimate the sort of the broader impacts on people's lives that we as clinicians don't see when someone comes up to our clinic and sees us for 15 minutes.
And that's really helpful, the shared decision making, patient-centered indeed, hearing from patients themselves what helps. Deji, I'm wondering, do you have any examples of strategies that have been effective in helping patients manage and navigate this condition day to day?
Yeah, so our practice is very similar to Toby's. We have very similar support structures in place as well. Social workers, respiratory therapists, pulmonary rehab providers, and all that gamut of healthcare providers who help the patients. One thing Toby said really resonated with me, the fact that patients with pulmonary fibrosis often have to deal with the blindness of other people around them to the challenges that they face. That is real. That is exactly what our patients often have to encounter. And many people don't realize that pulmonary fibrosis is a whole life diagnosis, right? Beyond breathlessness and cough, patients often have very high rates of anxiety and depression. They have to deal with social isolation, the financial strain on their finances, the caregiver burnout, fear about oxygen or the future. All of these things for them, they're not side notes, right? They actually drive the quality of their life, their day to day lives. It drives their adherence to therapies and even the risk of hospitalization. And so, what support strategies do we have in our practice that actually can help these patients? I think, in my experience, a few strategies I've found to work in real life are from the name support groups, right? It can either be virtual or local. We have a few here that are virtual. They take place on Saturdays. And then we have the ones that happen during the weekdays, but at specific times for a select group of people in person. And patients often repeatedly tell me that hearing another person say, yeah, me too, that changes everything for them, right? The Pulmonary Fibrosis Foundation has a national network that really begins to make this easy. And you can actually have patients actually link up with support groups using the online website for that. They have links and other similar support groups around the country. Pulmonary rehab is another one that I think really begins to make sense for patients. There's data now, really compelling data. Pulmonary rehab improves exercise capacity and dyspnea. And a recent chest publication, I think, also shows that pulmonary rehab may actually improve life expectancy, a retrospective observational large cohort, but it showed some life expectancy benefits to instituting pulmonary rehab for our patients. And so I often pair that with a home plan for patients to walk at home, either around the home, in the park, around the house, and use a pulse oximeter while doing that. So again, that necessitates education on what a pulse oximeter means and how it can help them gauge their exercise tolerance and what they should not do. For patients, it's a way to measure progress, right, on a day-to-day basis. Some people do the singing for lung health. I have patients that do that. It's a breathing focused program in a roundabout kind of way, singing, not really focused on breathing. But the evidence is still growing. But I know that there's data that also suggests that structured voice programs can help with symptom control and also help patients connect socially, thereby hopefully mitigating some of the anxiety and depression that we talked about for patients. And then I'll point out that telehealth, which I mentioned earlier on, can also be used for telesupport or remote monitoring. Now we have multiple ways to actually help monitor patient symptoms remotely, right? We have nurse callback programs. We have technology that can help extend the clinic into the patient's home for their benefit. This is really important for rural patients who don't live in the large urban centers, right? And now we begin to use that for checking symptoms, welfare of patients, helping to reinforce inhaler therapy or technique, helping to reinforce the necessity for supplemental oxygen. And even it can arguably help us catch problems earlier, detect issues that patients encounter sooner. And then lastly, I'll just talk about patient stories, because I think stories are a very compelling way to capture the narrative and help patients understand that they're not alone in all of this. And so in my practice, I often will point patients to trusted story series from reputable pulmonary fibrosis organizations. You heard Dr. Maher just talk about Google earlier on. There are many other online repositories that we can go to. In fact, I will tell you that AI is becoming a big player in the field now. It's ChatGPT, Grok, all the different AI modules that you have. You actually can help pull important or similar stories that patients encounter using such AI algorithms. I think stories really begin to reduce the isolation that patients feel and also spurs on their ability to cope with such difficult situations. So, to put it simply, I would say small, reliable efforts at support groups, particularly when delivered early, they can help compound such complex narratives that patients encounter on a daily basis into measurable improvements in how they live with their disease, with pulmonary fibrosis.
Thank you. And Toby, we spoke earlier about treatments evolving in the past decade or so, coming up to date. What about how do you see the role of healthcare providers evolving in terms of encompassing more of the holistic approaches that Deji mentioned there? What improvements would you like to see or perhaps are evolving now?
Yeah, I think we've partially alluded to this already, which is to say, I think pulmonologists need to be comfortable with managing chronic disease, that managing IPF is different to managing asthma, for instance, different to managing infectious diseases like tuberculosis. And it's very different to the sort of day-to-day practice on the critical care unit that is sort of the bread and butter of many of our pulmonology colleagues. It requires a very different mindset. And secondly, I think it requires support. Managing chronic diseases goes beyond the 15, 20-minute consultation. It's not all as simple as prescribing a drug and walking away. It is about providing support to patients that goes beyond just pharmacological intervention, whether that's pulmonary rehabilitation, whether that is patient and carer support with, perhaps getting funding for their electricity bill to compensate for the fact that they're using oxygen and using a lot of electricity for that. So all of these things become very important, and one needs a much more holistic approach to managing the patient. And really, to do that, one needs a team of individuals that offer different components of that care, whether it's the respiratory therapist doing the pulmonary rehab, whether it's the social worker that's able to help find financial support for the individual. A lot of our patients, as their disease develops, will lose weight, and so our dietitian is very important in helping them understand the importance of calorie intake, maintaining protein intake to help build muscles. So it's very much a team-based effort when it comes to managing patients with a chronic disease like IPF. And so I think what we need to see in the pulmonology space, and this has happened over the last 10 years, but it's still something that's evolving. I don't think we've fully developed everything we need, but we need to be moving to this model of chronic disease management and everything that entails, really.
And Deji, what about towards the end of life? What about the approaches to palliative care and the integration of services there to support patients and their families?
Yeah, so with palliative care, a lot of people think of it as a stop, which is unfortunately not what it is, right? From the term palliative care, it really is meant to palliate or alleviate symptoms. It should be focused on symptom control. And I think the narrative has gotten out of hand in certain ways where people think of it as almost hospice care. And that really misaligns that term when patients hear it, making it very difficult for our patients to actually come to terms with the need for it. I think we need to pitch it as an extra layer alongside other therapies focused on their disease, not a stop sign, right? And so being able to tell patients, we're going to focus on your symptoms, on your dyspnea, on your cough, on your anxiety. We're going to help with making you feel better. I think it makes it much more appealing, makes patients more amenable to it. And along the side with that, we can actually start to build in advanced care planning on the patient's timeline, not on ours, right? So that way it becomes much more acceptable to patients and their caregivers, and they're able to, integrate it into their regular hospital care or clinic care. There's really compelling evidence now that suggests that early palliative care programs can reduce crisis care, which our patients often encounter in the context of acute exacerbations. It can also help support their preferred care settings, particularly for those who have issues with access to care. We talked about earlier on some healthcare disparities where not everybody has the same access to care. And many patients, where I practice at least, depend on safety net hospitals to help deliver the care that they so often need. But when you institute palliative care early and appropriately, they can choose what is their preferred care settings in a way that works for them and for their caregivers alike.
So let's focus now a bit more on the role of primary care in ILD diagnosis. Perhaps Toby, first, how has the approach to diagnosis changed, and what are some of the key challenges in recognizing pulmonary fibrosis in primary care settings, and how might that be improved?
So yeah, I'll start by saying primary care physicians have a challenging job because Deji and I can focus on IPF or interstitial lung disease because that's what we do, and someone has already sorted the patients for us, generally speaking, before sending them to us. So we already know that there's a high likelihood this patient has a lung disease and that they have an interstitial lung disease. Primary care physicians don't have that luxury. They're often seeing patients reporting symptoms for the first time. And there are many causes of exertional breathlessness, particularly in older adults, including cardiovascular disease, COPD, asthma, and IPF is only one of those potential causes. So I think the first step in the recognition is just to remind people that IPF is one of those causes, that when seeing an older adult who is complaining of exertional breathlessness, I think it's important that primary care physicians have IPF on their differential diagnosis somewhere. It doesn't have to be top, but it just has to be thought about, so that if the patient doesn't turn out to have cardiovascular disease or they don't respond to the inhaled bronchodilators, the next step is to think about IPF as the diagnosis and to perform the necessary tests to potentially exclude it. Personally, I would encourage doing something as simple as chest x-rays as a useful screening tool. We would never diagnose IPF with a chest x-ray, but it would be unusual for a patient with IPF to have a normal chest x-ray. So as soon as you find the abnormal chest x-ray, that would be a trigger for the patient to be referred to a pulmonologist for more detailed assessment with a CT scan. And then I think the third thing is the clinical examination. So patients with IPF tend to have very characteristic finding when you listen to their lungs, which is the sort of dry Velcro crackles. So again, part of the assessment of an individual presenting to their primary care physician with breathlessness should be to listen to the breath sounds. And if crackles are heard, that should again trigger the thought that this might be IPF and that this patient should really have a CT scan as the next stage in their investigations.
And Deji, you'll be familiar with the work of Dr. Molly Parker in managing and diagnosing pulmonary fibrosis in underserved areas. What lessons are there from this model of care?
Yeah, I think there are really important lessons that we can learn from Dr. Parker's model. I think the big idea here is capacity building where patients already are. Right, it's taking the treatment, the care package to meet them at their doorsteps. Right, in community and underserved settings, you won't fix access issues overnight. We know that already, because of the challenges and the hurdles that have to be crossed with it. But you can help redesign the path for these patients, right? And I think one of the first and cardinals approaches to this is what Toby actually mentioned earlier on. So disease recognition at the front door, right? We talk about the fact that chronic cough and exertional dyspnea are seen very often in other disease entities beyond IPF. But that should also trigger our senses as a red flag. When patients come in with chronic cough with exertional dyspnea, I would say take 2 seconds extra as a primary care doctor to just listen to the lungs and hear if you hear Velcro crackles. That is really important. The minute you have all three in any given patient, you really want to start getting a spirometry and a DLCO. And ask yourself, does this patient require an HRCT? Right? That's the flowchart I think we should walk through. And Dr. Molly Parker's work has really very nicely elucidated that. The other thing that it really brings to bear is telehealth partnerships with ILD centers. Not all centers are able to have the expertise needed to care for pulmonary fibrosis patients, but when you are able to partner with an ILD center for at least virtual case review, it doesn't have to be in-person referral, and a radiology read, that brings MDDs, like we talked about, to their doorstep, to the clinic, rather than exporting every single patient to the tertiary healthcare centers. I think thirdly, which Toby mentioned earlier as well, is the need for education of our primary care teams. And that really is really, really important to highlight the importance of symptoms, of signs that may allude to pulmonary fibrosis and point to when we need to escalate therapy for these patients or escalate interventions to help change outcomes. There is also the role for patient-facing education, not just provider education, right? Where in plain language terms, we can actually provide meaningful education and enlightenment to our patients, and also hopefully provide them with links to the Pulmonary Fibrosis Health Center, to local or virtual support groups to help them understand their disease better and know what to do and what not to do. I think all of these are really important in blunting that detrimental outcome trajectory that we see in patients with pulmonary fibrosis.
And Toby, thinking about expanding treatment options, as we were discussing earlier, what would you like primary care clinicians to know about the importance of their role in the pathway for patients with pulmonary fibrosis?
I think that comes back to this sort of holistic approach to the management of chronic disease. So I wouldn't expect primary care physicians to have a sort of direct role in prescribing pharmacotherapy for patients with pulmonary fibrosis. I think that needs to be a pulmonologist with expertise in the management of IPF. But I think all the other components of chronic disease management, supporting patients with symptoms, supporting patients with lifestyle change, supporting carers, being involved in end-of-life care as the patient develops worsening respiratory failure, managing the patient holistically, because patients with IPF tend to be older adults who've got multiple comorbidities. They'll often have cardiovascular disease, often have type 2 diabetes, and certainly we know that managing the patient as a whole and not just as a series of organs will also improve outcomes. So I think that the primary care physician is really very well placed to ensure that very holistic management and to sort of integrate with the wider care team in providing support for a patient with chronic, potentially life-shortening disease. So they should be an important part of the team that is looking after the patient. And of course they can, often they're the first person that sees the patient if there's a problem, as a physician to alert the pulmonologist to any issues such as evolving acute exacerbations.
Well, thank you. You've both covered so many important insights into the care, the management of patients with pulmonary fibrosis. And I wonder if you could sum up, each of you, perhaps Adegunsoye first, some final thoughts, some key takeaways on caring for patients with pulmonary fibrosis, where that's heading, how clinicians can work together. Your overview, please.
Yeah, I'll say that for our community providers or primary care pulmonologists who may be watching this video, I'll want to let you know you're the first line of defense in this disease. And this is what I want you to really carry forward. I think early recognition and referral is critical because it saves lung function. So if you hear Velcro crackles, if you see unexplained exertional dyspnea, if you see a low DLC with all these things, just pull the trigger and order the tests and start the conversation and loop in an IRD partner early. I think doing these things can really be game changing for your patients. The 2022 guidelines anchor the pathway in which we should care for these patients. And our options are actually now expanded with a new class of therapy along the tools that we've had for years and years and decades. So I'll encourage you to stay current. I'll tell you that when you do this, your patients will feel the difference. Secondly, build networks. Virtual MDDs are now a thing in medicine. And so touch points, having partners for pulmonary rehab, having patients referred early for palliative care, all of these can actually make a huge difference. And it plugs patients into the ecosystem early so that no one walks this road alone. They're not felt to be alone in this space. And finally, I would say just have a hopeful, realism for our patients. We cannot cure pulmonary fibrosis today, but we can protect lung function. We can delay oxygen. We can reduce crisis. We can maximize meaningful quality of life for our patients in the meantime until someday we can cure pulmonary fibrosis. So I'll say every month gained is a lot for patients. Every breath that's made easier, it's meaningful for patients. And that's the work you have to do. That's the work we also have to do. And together, primary care, pulmonary medicine, radiologists, rehab, pharmacy, palliative care, all of us together with the patients, we are shifting the silence around this disease into a coordinated, compassionate chorus that makes sense for our patients and hopefully improve outcomes for them as well. So thank you.
Toby, can you add to that your thoughts for the future?
Adegunsoye summarized it all very nicely. But I think it is important that we remember how vital our lungs are to what we do day to day. I think that the keys points with IPF, firstly, we need to diagnose it promptly. We need to recognize what a significant condition it is, that once we've identified a patient with IPF, we are essentially saying that they are on a one-way journey to respiratory failure. We need to recognize that while we have treatments, what those treatments do is preserve lung function. And so if we are to stand our best chance of allowing our patients to live long lives that remain fulfilling, we need to try and preserve that lung function from as early on as possible. And so from my perspective, early treatment to try and prevent disease progression is vital. We shouldn't forget all the other things that we can do to help the lungs. So exercise and rehabilitation are vitally important. Trying to minimize the risk of infection through vaccination, vitally important. And then, of course, there's, as we've discussed, the role of the wider team to really work on supporting patients in living with their disease, because there is a lot that we can do in terms of lifestyle support that allows patients, even with advanced disease, to live good quality lives, whether that's allowing patients to still travel, whether it's allowing them just to be able to go to a restaurant or a theater and enjoy time out with family and friends. It's vital that we as a medical team are supporting patients through that journey with idiopathic pulmonary fibrosis. And as Adegunsoye has said, we are at an exciting position where we're seeing the development of new treatments. We've come a long way in my career so far. When I first started, we couldn't do anything really for patients with IPF. Now we have options, and hopefully by the time I retire, we'll have moved the needle even further. So I think there's a lot to be done, and it requires a lot of teamwork. So I think we're at an exciting place, and it's important that we all work together to move things further forward for our patients.
Well, thank you both so much to Professor Toby Maher, to Dr. Ayodeji Adegunsoye. Those insights have been absolutely fascinating. Thank you to everybody who's joined us to listen to this on the AMJ podcast. But speakers, thank you both so much. It's been great talking with you.
Thanks for having us.
Thank you very much.
And you can find a wide variety of further topics of medical interest by going to emjreviews.com or subscribing wherever you find your podcasts. From me, Sue Saville, thank you very much for joining us.